Good evening. I am Bertha Cooper, a member of Clallam County League of Women Voters and the Healthcare Access Committee, and I will be your moderator for the evening. The League welcomes you to the third of 4 important forums on the urgent need for broad healthcare reform. We are pleased to share sponsorship of these forums with Olympic Medical Center, and we are also very grateful to Peninsula College, who has given us the use of this fine venue called the Little Theater. Thanks to all of you for coming. We're happy to see you here. The goals of our forum are to make the case that the cost of health care in America is unsustainable and must be reduced and controlled. To make the case that the cost is seriously limiting access for millions of Americans. To present and inform our community on the various sides of the healthcare debate that will be part of our decision making. And to raise the voice of the public in expecting our elected policymakers to do the hard work of reform. When the League Committee on Access to Healthcare planned these forums early this year, we were struck by the growing debate around the role of government versus the role of capitalism or the free market in the provision of health care. Anyone listening cannot help but puzzle that many do not seem to see the existing role of the market in our current system or see the existing role of the government in Medicare. Our speakers tonight will provide the contrast in the roles and issues of government and the free market in the provision of health care in America. Again, I will point out that in this age of sound bites and campaign slogans, tweeters and minute-by-minute communication, it is hard to get below the bites and tweeters to hear the information we need to know to decide for ourselves. Our intent tonight is to get below the sound bites and present information and points of view and provide opportunity for dialogue and thought. But before we start the program, I must first tell you about the League of Women Voters. The Clallam County League of Women Voters is affiliated with the National League of Women Voters. We are a nonpartisan, nonprofit organization. Our focus is on issues which affect all people regardless of political persuasion. Issues such as water, environment, education, and health care. We also present election forums with political debate between the candidates and about the ballot initiatives so that people can be informed voters. Keep watching your newspaper and the calendars for upcoming debates that will occur before the November election. Conducting forums like this is one way the League encourages informed and active participation in government. That's one of the goals of this forum. Your participation tonight helps us carry out our mission. The League takes no position on the statements made by the speakers, other than we think it's important to listen to their message and decide the importance to you. However, in the interest of disclosure, we want you to know that the League has developed position statements in some areas and not in others. In the case of health care, the national, state, and county leagues have a position on health care reform which is in support of universal access to affordable care. The county's position also includes support of single payer. The League's website have been included in the program if you wish to read the position statements. But we are not here tonight to discuss those positions. Rather, our intent is to give you information, to inform and to involve you in becoming a voice in the need for health care reform. The voice will be yours in whatever your point of view becomes. We believe that our policy makers will respond to voices that expect them to do the work of reform. And now, a brief pop-up, and one you can't delete. If you like programs such as this, please donate to help us continue to provide them. Our speakers are generous in donating their time but we think it's only fair to pay their expenses in a humble honorarium since we have invited them into our communities. And remember, we have still another forum to go. Look for the big donation jar before you leave. As I mentioned, this is the third in a series of forums. I will summarize the points from our first two forums in a moment. First, the remaining forum. The fourth and final forum will present solutions from big picture solutions like the role of prevention to financial mechanisms such as single payer and a voucher system intended to reduce cost and increase access, to structural reforms to reduce cost and improve results, to reducing access variability to improve outcomes, and to influencing elected policy makers. Many more attended the second forum than the first, and I suspect there are people here tonight attending for the first time. We understand it's like coming in the middle of a movie. I'm going to highlight the points from our first two forums, and I'm sure you're going to hear some of them again as our speakers make their point. Forum 1 showed us that healthcare costs are unsustainable for the nation, businesses, families, and individuals. We are a voluntary employer insurance-based system that doesn't provide for universal access. Many small businesses are unable to provide health coverage as a benefit due to cost. Unless employed with healthcare benefits or on Medicare, Medicaid, Veterans Benefit, or some other program, the average family with the average income cannot afford health insurance unless it's insurance with a high deductible and co-payments. Rural hospitals such as Olympic Medical Center are caught. They're caught in increasing costs, escalating charity care, declining reimbursement, and people delaying care in a business model dependent on volume. Growing volume as a primary business incentive is one of the structures of our current system that results in greater cost. The second forum focused on ethical and moral questions surrounding the healthcare debate. We heard agreement on the need for universal access. We heard disagreement on how universal access can be achieved. We heard disagreement around who and how to finance health care. We heard disagreement on the role of government, and we heard disagreement on the role of charitable care. This brings us to tonight and our speakers. We are focusing on contrasting the role of government, the role of the market, and do they, should they, can they effectively meet? Our two speakers will each speak for about 30 minutes. When they're finished, we'll open the program to the audience. Our first speaker is Aaron Katz, who will speak to us from a public policy point of view, something he is well qualified to do. Aaron is Principal Lecturer of Health Services at Global Health in the School of Public Health, University of Washington. He teaches several health policy courses for MPH, Masters of Public Health, and MHA, Masters of Health Administration students, including community-oriented public health practice and global health MPH programs. Aaron is the Director of Leadership, Policy, and Management track of the Global Health MPH program. He is Director of the Health Policy Analysis Program for 15 years, he was, from 1988 to 2003. His current research interests focus on strengthening public health systems in developing countries. Additionally, Aaron is involved in long-standing research on changes in the safety net system and healthcare markets in the United States. Aaron received the American Public Health Association Award for Excellence in 2006 and the School of Public Health and Community Medicine Outstanding Teaching Award in 2004. I took this quote from his university website because I liked it. Aaron says, "I work in health policy because it involves issues that touch people's lives, and because of my mother. My other passions include traveling with my wife Kate, gardening, tennis, softball, reading, music, and all things garlic. Please welcome Aaron Pat.
Thank you. Good evening. Just a note about the softball. I played on a softball team here in Port Angeles between 1978 and 1979. I think we did pretty well. I can't really remember. It was a long time ago. Anybody play on that team? Well, it's great to be here. I haven't been to Peninsula College probably in, 34 years. But I managed to wind my way up the hill without looking at a map until I got within about 2 blocks of here, and then I got lost. But I had enough time. Anyways, this is great. I really want to congratulate the League on having such a comprehensive series on healthcare. It is, as you all know, very complicated. It's worth a lot of our time, not only because, as that quote said, it touches all of our lives, but because it consumes a lot of our resources. And as a result, and as I'll show you in a minute, it matters to us as individuals, as families, as a society. Before I get to my slides, let me just cut to the chase about this business of government and free markets. In fact, you know, being a good academic now, I should spend the next 30 minutes taking issue with the definition of these terms. Because I don't like, the notion, free markets, what are markets? Markets are where people who want something buy it, people who have something to offer sell it, people who are producing things get it to people who want to buy them. It doesn't have to be, profit motive is one element in most markets, but you can have a market of nonprofit organizations. In fact, in this state, we have a market of hospital services that I think all but 2 hospitals in the state are not-for-profit organizations. Sometimes it may not seem this way, but the big players in our health insurance market are all nonprofit organizations. Premera Blue Cross, Regions Blue Shield, and Group Health Cooperative are all nonprofits. So the profit motive is, in my view, not a necessary ingredient for a market to be working. That's not to say I don't like profit motives. I like my own profit, for example, and you probably like yours. But the point is that I guess as a teacher, I would urge us in this conversation to think creatively about what markets can do for us, what governments can do for us, and how these mechanisms might be able to help solve these very big problems in the health system. I also have a big problem with this definition of government. It says a group of people who have the power. Well, excuse me, but who elects those people? Who are they accountable to? They're accountable to us. Government is us. Sometimes we don't like to think that because government does lots of bad things. But I think it's important in this democracy that we own this notion of government. Okay, I was lecturing to you. I don't like to lecture. I apologize for that. Okay, I am actually in a couple slides going to meet the first 2 goals, which is make the case why healthcare is costs too much. So, Roger, you don't have to cover this. Okay. So, and if you come to the other 2 forums, you've probably seen numbers like this, but this just shows that healthcare expenditures in the United States, this is on a per capita or per person basis, which is the unit I like to use because it takes out the element of population growth. So on a per person basis, you can see that we have been spending more and more every year for a very long time, and right now it's more than $8,000 per person. That means man, woman, and child per year. So that's a lot of money. and it's been going up a lot. This is a comparison of our spending versus other Western industrialized countries. Again, you've probably seen numbers like this, but it shows that we spend a lot more than other countries. And the big question that we're still grappling with, I'm going to show you some information that suggests some answers to this question but the big question is, why don't we seem to be getting the value out of that extra investment that we're making over Switzerland or Norway or these other places? Because if we were getting more value, if we could convince ourselves that, hey, we're getting $3,000 more a year than, who would that be? $3,000 would be Canada. Okay, we'd say the investment's worth it, right? If you buy a Porsche and the extra stuff you get with a Porsche over a Ford is worth it to you, then it's worth the extra investment. So it's not, the dollar amounts are only part of the story. It's what do we get for this extra investment? And I'm going to suggest to you that it's at best questionable that we're getting value for that extra investment. And the other thing to point out is that the fact that we're spending a lot more than these other countries isn't news. And as you can see here, the gap between us and these other countries have been growing for a very long time. So there's something going on here that may be different than is going on in these other countries, and that's worth looking at. Okay, and then the why does this matter? Now, it matters because, as I said, this is using a lot of our resources, and that's true at a number of different levels. So at this level, you can see from this chart that each year, and this is a difference of, I have to get my glasses here, a difference of 5 years, that each year we as individuals and as families are spending more on health care, and businesses, our employers who are offering coverage, are spending more. And at some point, more becomes too much. So this is an affordability problem. Now, I just want to take a little aside and note that this is in contrast to what some people, and notably Newt Gingrich, has written about that says, look, we're spending 17% of our GDP on health care. Well, maybe it should be 20%, or maybe it should be 25%. Well, the reason it shouldn't be, and the reason that we have to figure out how for it not to be, is that this is an affordability issue. This is using up our hard-earned money, and we don't have endless amounts of money. Now, one of the consequences of this picture is this picture. That is that while it's true that our health insurance system is an employer-based model, in fact, that model has been eroding over the years. As healthcare costs have increased and become less and less affordable, both to businesses and to their employees, employers have become less and less likely to offer coverage. It only makes sense. If the costs go up too high, they're not going to be able to provide coverage. And that's what's been happening. And as you can see, that it's largely government programs that have been picking up the slack over time. So again, when we get to this point about, well, government versus the market, the reality is that government is already playing a large role. And I don't see how this would change dramatically anytime soon. And I'll show you some more information that relates to the same. Well, affordability also works at the state level. You've probably been hearing a lot about increases in tuition at the four-year colleges around the state, and including and especially the University of Washington, where I work. Tuition has gone up, I don't know, it's probably close to 100% in the last 3 or 4 years. That's not because costs have gone up. In fact, the cost of a 4-year college education at the University of Washington is about the same as it was in 1975. What's changed is that the state legislature has sent less money our way. And one reason, not the only reason, this isn't a forum on taxes, so I'll set that aside, but one reason why the legislature has withdrawn much of its support, 50% of its support from the University of Washington, is because healthcare is the Pac-Man of the state budget. I don't know what you feel about unions in general, or teachers' unions in particular. I know there's a lot of pejorative stuff around about teachers' union being sort of the bully in Olympia. But I'll tell you, after working in and around Olympia for more than 30 years, when push comes to shove, or said another way, when the doctors and hospitals come down and battle over money versus the teachers, we know who wins every single time. The doctors and the hospitals, when they say, if you don't give us this money, people are going to die, and it's not that it's untrue, but versus the teachers who say, we're not going to be able to teach your kids as well, we're going to have larger sized classrooms, etc. What happens is the doctors and hospitals win. And that's why the pieces of the pie here that are going to healthcare have been going up steadily for probably at least 25 years. Hopefully I've established that healthcare costs are making healthcare unaffordable and also affecting our ability to do other important things. Oh, I should say as an aside, so as Bertha noted, I'm in the School of Public Health at the University of Washington, and I'm obligated to tell you that education, the educational level of a population, is much more important for the health of that population than medical care is. All of the data, all the research pretty clearly shows that. So what we're doing here is undermining the ability of the state to educate its kids and therefore improve the population in order to pump more money into what is as I'll suggest here, a fairly wasteful healthcare system. And I want to talk about that in the form of some myths, because I think we have a lot of myths about the healthcare system and why costs are going up and where the money goes, and I want to try to dispel some of those myths. So the first really has to do with the nature of our healthcare system. We have said for many, many years we have a private healthcare system. Government plays a big role, as you saw with the coverage changes, but it's a private healthcare system. And that has been true for a very long time if you look at where the money comes from. But that's no longer the case in terms of the majority of the money. If you take into account the roughly $200 billion every year, that's essentially what's called a tax expenditure. That's taxes foregone because of tax breaks. And these tax breaks happen to be the fact that every one of us who has worked and gotten coverage through our place of employment gets a tax break on that income, right? I'm getting 100% of benefit but it doesn't cost me that. And the value of those tax breaks, and employers get a tax break too, is about $200 billion a year. So if you take that into account, the majority stakeholder in the American healthcare system is the public, us, our governments. That's where the money flows through, but the public. Okay, so this myth about the private versus the public. And one of the things you'll hear a lot about, particularly in this campaign season, is that public programs are inefficient. They're wasteful. The governments can't run anything. But if you actually look at the data, you see here that it's not at all clear that the rate at which Medicare spending goes up is any higher than the rate that private insurance goes up. It varies by year, okay? So I think it's reasonable to question the notion that Medicare is, quote, inefficient as a government program. Well, what about Medicaid? A lot of Medicaid expenditures are for long-term care, nursing home care, and the like. So if you take that out, because that's very different than what you get in private health care insurance, and you make that equivalent, you actually see that over this period, over the period of the 2000s, Medicaid spending actually rose on a per-person basis slower than private insurance. Okay? So I think it's important. This doesn't prove anything. I'm not trying to prove things with these little data points, but rather to raise questions about, again, what we tend to hear, the pejoratives about public programs being inefficient and they can't do anything, etc. That I think there's reason to question that. The second myth that we live under is the U.S. has the best healthcare system in the world. And there's actually evidence in some areas that suggests that we do some things really, really well. We do some things very, very well. Particularly in the Northwest here, we have, I don't know, but probably one of the best, if not the best, emergency response systems in the world. We do that really, really well. Publicly funded, by the way. But we do that really well. So it's not that we don't do things well, but the question is, are we the best in the world? This is really complicated. You can go look this up on the Commonwealth Fund site. The Commonwealth Fund, for about the last 10 years, has been doing comparisons between the U.S. healthcare system and other Western industrialized systems, not on cost, but actually on the care provided. And they've created some composite, combined indicators, and those are on your left. Quality care and some subsets there, access, etc. So this is comparing Australia, Canada, Germany, the Netherlands. I don't know what happened to the Netherlands map. New Zealand, United Kingdom, and the U.S. And you see that on these rankings, so higher numbers are worse. That the U.S. doesn't fare very well in general against these other countries. And remember, there's some numbers, slightly older numbers, in terms of how much they spend each year on the bottom. So again, thinking about the investment. Spending more isn't necessarily bad if what you're getting out of it is worth it. Well, this raises some questions about whether we're getting value out of the extra investment that we're making. And another thing about the American healthcare system that I think you all know, we all know pretty well, is that there's a very, very heavy administrative burden on this system. You'll hear things like, oh, we spend 12, 15%, 20% on insurance overhead or whatever, something like that. Well, it's worse than that. Not in the insurance arena directly. This is a rough estimate based on some analysis I did now. You can see this is 21 years ago. It's a long time ago. But looking at administrative activities in doctors and hospitals, and that's where the majority of administrative costs are in our system. And the reason is understandable. Every physician's office and every hospital has to be a business center to deal with the plethora of insurance plans and insurance products and different ways insurance companies pay and different data that the insurance companies require. So in many medical offices, you'll have more billing clerks than you will have nurses. And the number of administrative staff has been growing much faster than the number of clinical staff. So this is also should raise some questions about the nature of our, about the efficiency of our healthcare system. We put a lot into administration. Now the third myth I want to talk about is the notion, and this is very, very important, the notion that we use too many medical care services. The reason this is very important is that many of the proposals to fix the healthcare system are based on this myth. They're based on the notion that we use too many healthcare services. They used to say the allegation is we take recreational visits to the hospital and the doctor. I don't know about how many of you enjoy going to the doctor and hanging out at the hospital, but I sure don't. I don't know that many people do. But this notion that we use too many services, and that's the problem. So if we just use fewer services, we would have a more efficient system. And thus you get the advent of high deductible health plans, the idea being that if people have money in their pocket or the equivalent in a health savings account or something like that, so it's their money, they'll be more economical in the use of that money, okay? And then they'll use services less. So I'm not going to debate that model, but rather know that the premise there is we're using too many services, we need to use fewer services, okay? Well, this is just not true. So this is just one set of data looking at hospital data comparing Canada, France, Germany, Switzerland, and the US. And you can see that it's not at all true that we use many more services than these other countries who are spending a lot less than us. That's just not the case. And I could show you data on physician visits and physician services, and it would look very similar. And if you look deeply, for example, at Canada or Japan, Japan's a really good one, hospital lengths of stay, I don't have that on here, they used to be around 20 days. Every time you went into the hospital was 20 days. So the notion that the problem is that we use too many services, I mean, it's not to say that there isn't overuse. I'm not trying to make that the case. But that's the main problem that we have to solve, I think, is just not supported by the evidence. What is supported by the evidence is that the reason that we spend more than these other countries is we pay higher prices for everything we get. Every day in the hospital, every stay in the hospital, every pharmaceutical drug, every physician visit costs us more, much more than these other countries. And I found this is Health Affairs is like the premier health policy journal, so I read a lot. And this was a stunning, stunning graph to me. Okay, so let me interpret it. So the what's that blue color? That designer right here. I need a designer. What color is that? Aqua, thank you, aqua. So the aqua is how much total personal health care spending went up during that year. So that's sort of like the main number. So for example, between 2000 and 2006, the annual average increase in health care spending on a per person basis was almost 8%. Okay, then the yellow, something like that, yellow. I'll call it yellow. So this is the price. So this is the price of things. So the idea here is we're trying to figure out, well, why did healthcare go up an average of 8% during those years? Well, in this case, price made up about 2.5% of that 8%. And the green is population. So we grew older. I just want to point out, since I see a lot of gray hairs here, that population actually is relatively constant and relatively small reason why we're spending more and more every year. Just to point that out. Okay, and then the orangish rusty red is something called use and intensity, which is a combination of the number of services that are provided and what each service contains. So for example, we use MRIs now. We used to use x-rays. So one MRI visit is more intense. It requires more technology than the x-ray. So that's what that bar is. So 2000 to 2006, 2007, 2009. But look at 2010. This is in the middle of the deepest recession we've had since the Great Depression. And look at the price increases. Despite the fact that we were in the middle of this huge recession, prices still pretty much went up 2.5% percentage points. What is going on? What is going on that causes prices to sort of go up inexorably every year regardless? Prices are where we should be focusing our attention. Now, just to put a fine point on that, here's some comparisons of, I just picked hip replacement. This is out of, this is out of a Health Affairs article, but this is how much we are spending versus other countries, Australia, the UK, and France, on hip replacements, and also breaking this up between public payers and private players. And you can say, just if you look on the far right graph, the right-hand side, how much more we pay for hip replacements than these other countries. Now, it's not. I don't have any evidence, and it's worth asking. Well, are the hip replacements in the U.S. better? Do they last longer? Are they higher quality? I don't know the answer to that. It's a good question to ask, because if they are better, If they do last longer, then maybe this is worth it. But it's worth asking the question. Let's get to the market innovations. Now, I call it market innovations just because, as I said before, I don't like the notion of free markets conjures up some ideal. You know, there isn't a free market. There is no free market. Okay? Now, I mean, maybe illicit drugs come very close, but even that market is regulated by the enforcement policies of the police or the border patrol or whatever. Okay? Otherwise, there is no free market in the sense of a market devoid of government involvement. It could be government involvement just because government built the roads that allow the stuff to get from the producer to the market, or created the internet and put in the telephone systems, as they did in rural communities all over the country in the early part of the 20th century, including this one. It may be that government had that level of involvement, or maybe some other deeper level, like it does in healthcare, have a regulation, a role as a regulator. But the point is that there is no free market in that sense. There are markets and there are market innovations, and I just want to talk to you about what I have seen over the last over a 15-year period in which I participated in a research project, the same one over 15 years, looking at how healthcare markets were changing around the country. So I had the opportunity to see just about any innovation. By the way, how many of you work in the healthcare industry? Or have, or did? Yeah, look at this, quite a few. Very well-informed group. So you who did or are working in this industry know that there have been changes all the time. We've changed how we pay for services, we've changed how we organize services, and there's more in the offing because of the provisions of the Affordable Care Act. But I've had this opportunity to watch many of these innovations. And let's see if this is going to work. This is my only animation. I've seen it all. I've seen it all, from hospital, from the combining of hospitals and the splitting of them up, changes in payment, performance-based payment, fee-for-service with holdbacks. I can give you all of the jargon. I've seen it all. I've seen it all. And it's been very interesting watching it. And I'm not making the case that these innovations don't work. I'm not making that case at all. What I'm making the case about is that these innovations, when they do work, never proliferate beyond the organization where they're tested. They never proliferate beyond the organization in which they're tested. Let me just give you one example to ponder. It's a complex example, but one example. You know Group Health Cooperative? Yeah, you know. Extraordinarily innovative organization, right? I mean, it's fully integrated. They used to own hospitals. They don't do that anymore. And they basically employ all the medical staff, etc. They have a very sophisticated health services research program, so they're actually investigating the frontiers of research all the time. Very interesting model. Group Health has been around since 1948, 47, something like that, a very long time. Why doesn't Group Health own Seattle? Because they don't. Much less Puget Sound, much less Washington State, much less the Northwest. They don't own any of that real estate. Why not? What hampers the proliferation of good ideas and good models? And I'll end here. Just say that the problem is we have a healthcare system whose incentives are not to promote quality, access, efficiency, and cost control. We have a system whose incentives are to churn money, to earn profits. Again, I'm not negative on profits, but remember that profits are healthcare costs. And profits that don't produce quality and access and efficiency are not helping us. And we have a system that promotes that kind of inappropriate profiteering, inappropriate competition, inappropriate in the sense that it doesn't get us where we want to go, a system that provides the right care at the right time to people who need that care. Thank you.
Our second speaker is Dr. Roger Stark, who is well known for his writings and speaking on healthcare from a market point of view. Roger Stark is a physician and a retired cardiac surgeon. He is a healthcare policy analyst at the Washington Policy Center, one of the largest state-based think tanks in the country. He is the author of numerous healthcare studies, including the impact of federal healthcare reform on Washington state, and the book Patient-Centered Solution. Roger wanted me to let you know that he's left some handouts out at the table that you're welcome to take if there are any left. And also there are cards out there that offer a trial membership to the Washington Policy Center. So if you're interested, those are there. But meanwhile, back to Roger. Dr. Stark served on the governing board of Overlake Hospital in Bellevue and is the past chairman of the Overlake Foundation Board. He is a member of many professional organizations and is an active member in the Woodinville Rotary. Roger has had multiple media appearances in both radio and news television, and now he's here with us in Port Angeles. He is clearly passionate about the topic. Please welcome Roger Stark to our community.
Well, thanks very much, Becca. And I, too, would like to thank the League of Women's Voters for putting this forum on. I think this is a tremendous service to your community. Following Aaron Katz is problematic. He is so articulate and so well prepared. I sort of feel like Zsa Zsa Gabor's sixth husband on their wedding night. I know what I'm supposed to do, and I'm going to try and make this interesting for you. Actually, we're going to talk about many of the same things that Aaron Katz talked about this evening. There are four things, really, that I would like to cover. First of all, I'd like to cover the problem of healthcare, and obviously we've outlined that really the problem is the cost. Then I'd like to give you a little bit of history, how we got into this problem. And then thirdly, I'd like to discuss the difference between the free market and government intervention in healthcare. And again, there are a lot of similarities between what you've already heard and what we're going to discuss. And then lastly, I'd like to give you some of the solutions that I see as true free market solutions to our healthcare problem. Well, to begin with, and some of this is a review for you, but we'll all get on the same page here. To begin with, the problem with healthcare is the cost. It's about 18% last year of our economy, of our gross domestic product, or about $2.4 trillion. Now, let me put that in perspective for you. In 1930, we spent about 3.5% of our economy on healthcare. 1965, we spent about 5%. And in that 35-year period of time, it was relatively constant. It fluctuated a little bit, but basically between 3 and 5%. And then what happened in 1965 was we saw a rapid acceleration in the costs of healthcare. And this wasn't a linear acceleration, this was a curvilinear, a very rapid increase in the cost of healthcare in this country, such that we're now spending almost 18% of our gross domestic product. Now, you might be sitting there saying, well, Stark, I think that 18% is the exact correct amount that we should spend for healthcare. And I can't argue with you. But if we don't get off that rapidly accelerating cost curve, by the year 2040, we will be spending at least a third of our economy on healthcare. And obviously that cannot happen from an economic standpoint. So something has to happen to get us off of that cost curve. Well, the thing to ask yourself is, what is driving the cost? And we've heard some answers, some ideas about what's driving the cost. But really, there is an economic law at work here. And that economic law says that we do not spend someone else's money as wisely as we spend our own money. In other words, it's the third party, whether it's employers or state government or federal government, providing our health care, and that's what's driving the cost. Almost 90% of health care is paid for by a third party, by someone else. And as I say, we're not going to use that as efficiently as we would if we were spending our own money. So that's really the takeaway here. Now, we could debate whether health care is a right or not. We could be here all evening debating that, and I don't want to get into that discussion. But I think we can all agree that health care is a necessity of life. Just like food, shelter, clothing, those are all necessities of life. And think about this for a minute. We don't have our employers, we don't have the state government, we don't have the federal government providing food and shelter and clothing for us. If we did, I know I'd be eating a little bit differently. Hard for me to imagine, but I think my wife would probably have a bigger clothes closet if somebody else was buying her clothes. And we'd all probably be living in mansions up in the mountains or down on the Straits of Juan de Fuca if somebody else was paying for our food, shelter, and clothing. Now remember, those are necessities of life, just like health care is. We don't get food, shelter, and clothing in a government-controlled or an employer-controlled situation. We purchase those things in a free market. Now, is the government involved? Yeah, absolutely the government's involved. They are there to provide regulatory kinds of things to allow us to be able to shop for these different items. In other words, they're there to provide a market and a regulatory kind of environment so that we can go to Safeway or Walmart or QFC and purchase the things that we need in a competitive, open, free market kind of situation. Food, clothing, and shelter are not increasing at 2 to 3 times the cost of living. And it's because we purchase those things in a competitive free market that we're not seeing those increases. Now, second thing we wanted to do was a history. How did we get into this situation? How did we get into this problem of third-party payers in this country? And there are several dates that you need to keep in mind. The first date is 1943. Before World War II, most people either paid cash or they had some form of individual insurance for their health care. In 1943, we were in the middle of World War II. The government applied wage and price controls to everything in the economy, and we understood that. We understood the reason for it. It was because we were fighting a war, we wanted to win, and we were all pulling together. The problem was employers had a very difficult time finding employees to staff their industries. And so with wage and price controls, they couldn't offer more wages. And so the federal government said, well, okay, you can't give them more wages, but we will allow you to give your employees more benefits, and specifically health care benefits. And to further enhance this whole situation, the federal government said, and you, Mr. Employer, you will be able to deduct the cost of those health care benefits from your corporate or company income tax. That was the beginning of the employer model of health care providing in this country. And think about that. The employers don't provide food, clothing, and shelter, but they do health care. World War II ended, the wage and price controls went away, and yet we were stuck in this country with the employer model, such that by 1960, large companies like General Motors, General Electric, IBM, they were providing 100% of health care benefits for their employees and their employees' families. We now have 2 or 3 generations in this country of individuals, of workers who expect employer health benefits. The second date to remember is 1965, and that's when government got involved in the healthcare arena, healthcare sponsorship. In 1965, Medicare and Medicaid passed, and we'll go into that a little bit later. But again, that's when government got involved as a third-party payer. And then the third date to remember is March 2010, when President Obama signed the Affordable Care Act into law. And that added another 30+ million people to government-sponsored, government-controlled, government-regulated health insurance in this country. So, what are our choices then? The third thing we wanted to discuss was the 2 choices we had to deal with rising costs and to deal with this third-party payer system. Well, really, we have two mechanisms of controlling cost. On the one hand, we can allow government to control cost. On the other hand, we can allow the free market to control the costs. Now, what you need to ask yourself is, who is the most important person in this whole healthcare debate? And we believe that it is the patient. There's really no question about that. It's not the insurance company, it's not the drug company, it's not hospitals, it's not really the doctors either. It's the patient. But it's the patient as a consumer of healthcare that's the most important thing. So on the one hand, we have government. Now, government control of healthcare may seem very attractive. A single payer system, for example, it seems kind of efficient, kind of easy. But with government, we have a one-size-fits-all, or one-system-fits-all plan. It's centrally planned. It's top-down kind of a program. The second option is a consumer-driven plan, where patients are in control of their health care dollars. It's the consumer-driven plan that's going to be dealt with in the free market. Government plans are going to be dealt with in the political arena. And I think it's much more efficient and much more patient-oriented to deal with these issues in the free market. Ultimately, with government plans, there will be some kind of rationing. That will be the ultimate kind of endpoint. And the innovations that take place in the private market, things like health savings accounts, things like walk-in clinics, those occur in the private market. If we look at other areas of our economy, such as computers or such as cell phones, I had one of the first cell phones back in the early 1980s, and it was about this size, weighed about 40 or 50 pounds. It had a handle on it, though, so people said, well, it's portable. And now what we have phones that will fit in your pocket that you can not only talk to people with, but you can answer email, you can surf the internet, and so forth. Those innovations didn't happen in government-controlled programs. They happen in the free market. Now, let me be very clear about this. I agree 100% with Aaron in the sense that we do not have a free market in healthcare in this country today. We have a hybrid system. On the one hand, we have government with Medicare, Medicaid, TRICARE, the children's program, S-CHIPS, and so forth. The other side, we have the private market. But the private market with private insurance is very heavily regulated by the government. The insurance industry, at least in healthcare, does not function like the insurance industry for automobiles or for homeowners insurance or anything of that nature. And also, when we think of insurance, whether it's public or private, in this country, we talk about having great insurance. Well, what do we mean by great insurance? Well, we mean first dollar coverage, something that's going to include dental, eyewear, and so forth. What we're really discussing, the real definition then of good health insurance is actually health maintenance, right? Think of auto or homeowner insurance. With those, we have catastrophic kinds of plans to cover major kinds of catastrophic issues. Day-to-day things like filling your gas tank, cleaning the leaves out of your gutters. We take care of those things out of pocket. Health insurance is different. And when we talk about having good insurance, again, it's health maintenance. The other thing, whether it's government or whether it's private, we have no provider transparency in this country. In other words, we have no idea as a provider or as a hospital what our costs are. And you, as a consumer, as a patient, going to a hospital, you have no idea what you're going to pay for an x-ray or for a dose of antibiotics. I've ordered hundreds, thousands of x-rays. I have no idea what the costs are. That's ridiculous. We cannot have a free market unless we know what provider costs are. That will not only give us an idea of a competitive sort of situation, but it will also enhance quality overall. Now, one of the questions to be answered is, does a free market, does that provide universal access? Well, again, you have to ask yourself, does the free market in food, shelter, and clothing, does that provide universal access? And the answer to that is yes, of course. You can go into any grocery store as long as you're willing to pay. You can compare Safeway to QFC, and you can shop as a savvy consumer. We can't do that in healthcare, and that is an issue. Is there a role for government? Absolutely. Government is there in food, with food stamps. We have government housing and so forth. The same thing can apply to the healthcare market. In other words, government is there to provide a safety net and to provide an orderly sort of regulatory environment for patients as consumers. And the last thing in discussing the role of patients as consumers, there is an economic expression that's called information asymmetry. And you'll hear a lot about this, and you may be thinking this as well. What this means is, I go to a doctor, the doctor tells me what I need, and he has a lot more information, and I've got to go along with what he says. Well, it's absolutely true. The reason you go to a doctor is because he has more medical information than you do. But think about this. You go to a dentist, he's got more dental knowledge. You go to an attorney, he's got more legal knowledge. You get the transmission in your automobile fixed, he's got obviously more information, unless you're a mechanic, than you do about fixing your transmission. So in every one of those endeavors, every one of those economic activities, if you will, there is asymmetric information. And yet we have things to level the playing field. We have second, third opinions that are available. We have the internet. We have, as a patient, you can go to your primary care doctor, say, is that operation really necessary? You can go to your specialist. For example, I was a cardiac surgeon, as Bertha said. You could go to your cardiologist and say, is that operation really necessary, really needed? So there are ways of leveling the playing field as far as information symmetry is concerned, and that should not be an issue. The American public, we are some of the best consumers in the world, and I have no doubt that given the information a patient needs as a consumer, they can make intelligent choices for themselves and for their families. Now, what I'd like to do in the next few minutes is discuss a couple of government programs that already exist. We've had about 50 years of experience with Medicare and Medicaid already. And so where do we stand with these two programs? I'm a retired surgeon. Surgeons in general basically wanted to wash their hands of these programs, except for plastic surgeons, and they wanted to put a new face on it. And then the anesthesiologists, they thought the programs were simply a gas. The psychiatrists, they thought it was madness. And then finally, the obstetricians, the baby doctors, they thought when these passed that Congress was simply laboring under a misconception. So where do we stand with these programs? Well, let's look at Medicare first. Medicare, as you know, is essentially it's a single-payer system for seniors, 65 and over in this country. It's run by the government, passed in 1965. There was a budget that was set for Medicare. By 1990, 25 years later, Medicare was 7 times over that budget. Last year, we spent almost $450 billion on Medicare, and that number is expected to double by the year 2019. Medicare has an unfunded liability of about $40 trillion if the Affordable Care Act, if the provider cuts in the Affordable Care Act take place. If they do not, Medicare has an unfunded liability of about $89 trillion. It's one of the fastest growing budget line items for the federal government. There are about approximately 47 million seniors in Medicare now. As my baby boomer generation, as we age, in the next 20 years, there will be fully 80 million people in the Medicare program. The huge problem for our Medicare patients, however, is access to care. Medicare reimburses providers about 70% of what private insurance reimburses providers. And more providers, especially primary care family doctors, are finding that they cannot cover their overhead, cannot keep their doors open seeing Medicare patients. So it's an issue of, yes, our Medicare patients have insurance, but they're finding that they're limiting and having limited access to providers of health care. And that we see that as a real problem for our Medicare patients going forward. Medicaid, again, it passed in 1965. You may not be as familiar with Medicaid, but we've had now almost 50 years of experience with the program. It originally started as a safety net for children of poor families. It was an entitlement. There was really no budget for Medicaid when it began. It started, and actually still is, a state and federal combined program where the state pays roughly 50%, federal government, federal taxpayers pay roughly 50%. Medicaid, as I say, had no budget, but it was estimated that the first-year cost for Medicaid would be about $500 million. The actual first-year cost for Medicaid was $1 billion. By 1970, the cost of Medicaid was $5 billion. And Medicaid, the expenditures last year were approximately $430 billion. And that number, even without the expansion of Medicaid in the Affordable Care Act, the existing Medicaid number is anticipated to double again by 2019. Now, it's a safety net program, but unfortunately, you have insurance, but unfortunately access is an issue. Medicaid reimburses providers on average about 40% of what private insurance pays. And what we're seeing is fewer and fewer doctors, both primary care and specialists, who are willing to deal with Medicaid patients, again, because they can't cover their overhead seeing Medicaid patients. So this is an issue not only for Medicare, but also for our Medicaid patients. So those are two government programs that we already have 50 years, almost 50 years of experience with. So if you're sitting there thinking government is the answer, well, we've got two good sort of previews about what government programs would look like in this country and what access would mean. Yes, you might have insurance, but your access would clearly be limited. Let me just say one word about other countries before we get off this topic, and that is that every country is experiencing increasing costs, as Aaron pointed out. Every country is experiencing the same problems that we are, with an elderly population and a diminishing worker base to support that elderly population. And most, virtually all Western countries are grappling with the issue of healthcare costs exploding and getting out of control. And again, let me say this, I can't say this enough. Just having health insurance does not mean you have healthcare access in any way, shape, or form. So the last thing in the last few minutes, what I'd like to do then are discuss solutions, free market solutions that we think would work. Remember, the patient is the most important person in this equation. It's not the government, it's not bureaucrats, it's not drug manufacturers, it's not insurance companies, it's the patient as a consumer. The first thing we need to do, as we discussed, is we need provider transparency. In other words, we need a paradigm shift on the provider side so that providers compete for patients on cost as well as quality. They compete now on quality, but they don't on price. Physicians, providers, they have no idea what costs are. That's crazy. We need to inject provider transparency into this overall program. The second thing we need to do is change the tax code. Just as employers can deduct the cost of health care, we need to allow individuals either to deduct health care costs like employers do, or we need to eliminate that employer deduction. In other words, level the playing field there. We also need to think of health insurance as true insurance, not maintenance. We need to think of health insurance just like we do automobile and homeowners. High deductible, catastrophic plans with day-to-day kinds of healthcare activities paid for out of pocket. We have a tremendous mechanism of doing that now with health savings accounts, and we should see more utilization of those things. We also need to get government out of regulating insurance companies. In the state of Washington, if you buy a small employee or an individual health insurance plan, that plan contains 58 benefit and provider mandates. Now, these are for good things, acupuncture, chiropractic care, but if you're a teetotaler, why do you need alcohol treatment in your insurance plan? If you're a 25-year-old man with no children, single, why do you need obstetrical coverage in your insurance plan? And each one of those benefit mandates adds somewhere between 0.5% to 1 to 1.5% of the cost of that insurance plan. We need to allow more competition in the insurance industry so the insurance industry can provide the kinds of insurance plans that patients as consumers want and need. A simple thing to do would be to open interstate commerce in insurance, and we could do that with a vote overnight and get more insurance companies into the state of Washington, allowing more plans. We need meaningful reform to Medicare, Medicaid, and we need, again, to put patients in charge of those dollars. Not a defined benefit, open-ended plan. We need to allow patients to be able to make those decisions from a financial as well as from a medical standpoint. Just as an aside, we need meaningful tort reform, and there may be other things as well. There may be dozens of other things that I haven't even thought of that if we allowed the free market to flourish, we would see going forward. Now, the last thing, let me leave you sort of with an action item here this evening, and that is, when you leave here tonight and anybody discusses healthcare reform with you, and they have a plan that they think is the answer for healthcare reform, the first thing you need to do is ask yourself, who controls those healthcare dollars? Who is going to pay? Because the payer is the one who gets to decide what kind of health care you're going to get and how much health care you're going to get. And I would submit to you that if the payer is anyone other than the patient as a consumer, then this is an economic model from a cost standpoint that cannot be sustained. Demand will always outweigh supply, and rationing in some form or another will ultimately occur. I look forward to your questions. Thank you very much.